Yeah, my name's Dr. Robert Jeeves. I'm a GP in Middleton, Manchester, and I'm the primary care clinical lead for Summary Care Record programme. Thanks everybody for attending this event today and taking time out of your busy schedules to learn about the Accessible Information Standard. I'll start just to say my voice is slightly threatened. I've had a cough and a cold over the last few days, and I was recovering really well until my daughter gave me a get well soon card yesterday, which has sent me on a downward spiral again, so hopefully it'll hold out okay. We've been learning about the Accessible Information Standard, and so we've been thinking about how we identify these patients and how we then record that information, how we share that information, and how we can then act on that information to create those reasonable adjustments to support the care of these people. And Summary Care Record can help with that, so I'd like to tell you about that today. Summary Care Records are an electronic record of key information from the GP practice. As a minimum, they contain medicines, allergies and adverse reactions, but they can contain further information, which we refer to as additional information. The consent model for Summary Care Record is that meds, allergies and adverse reactions are provided on an implied consent basis on the back of a public information campaign. But further information, that additional information, requires the consent from the patient. Remember that when the patient presents for care, their explicit consent's required, so they give their permission to view the information when they present for care. So the patients have got control about who has access to their information. If the patient is unconscious or the patient is otherwise incapacitated and can't answer that permission to view question, then a clinician can make a best interest decision to access the information on their behalf. In terms of the availability of Summary Care Record, the picture over the last few months has been really positive. We've got nationwide coverage. 96% of patients have an SCR created. That's over 55 million patients. Indeed, when the microtest estate becomes compliant, just over 100 practices, then that'll push to about 98% of the population. The opt-out rate for Summary Care Record runs at about 1.4%. But they're also being used, so 2.5 million SCRs were accessed last year to support urgent and emergency episodes of care. That means 70,000 SCRs were accessed last week, approximately 6 a minute, so in a 20-minute talk now, about 120 SCRs will be accessed to directly support and benefit patient care. And that comes on the back of the work that lots of GP practices across the country are doing, so our thanks from the SCR programme to you for your contribution to that. In terms of the benefits that have been shown, we've shown those in terms of safety, effectiveness, efficiency and patient experience. We've put the benefits resources on our website, and I'd really encourage people, if they haven't had a look at them, to have a look at that information. We've presented it in terms of some audit data alongside some case studies to bring that information to life. I've picked out just a few key highlights to put on this slide. In terms of efficiency, obviously 29 minutes saved per patient when doing a medicines reconciliation exercise. So we've shown real benefits for hospital pharmacists, and that's published data in the Journal of Medicines Optimisation. But it does benefit GP practices because there's a reduction in phone calls and faxes and requests for information, which we've been able to demonstrate as well. We've shown safety benefits. 40% of patients have a medication error identified when the SCR is used. It's staggeringly high when this information is used. We're able to directly benefit such a high proportion of patient care. And effectiveness, 49% of patients are guided to a more appropriate care pathway when the SCR is used. Feedback from some ambulance clinical hub users. That quote there is from an emergency department consultant who says, "While I use SCR relatively infrequently, on every occasion it has directly informed, changed and better aided patient care. When we use it, it counts enormously and directly saves lives." So some really positive findings really in terms of the benefits we've shown with what we have already. But what I want to talk to you about is the additional information, so what more we can do with this resource. So GP practices have got the capability to enrich SCRs with a set of additional information with patient consent. That consent is one-off and enduring. The information includes the individual coded items and associated free text as that's recorded in the GP record. Essentially, SCRs include those items on the right-hand side of the screen. So, reason for medication, significant medical history, anticipatory care information, communication preferences, end-of-life information and immunisations. I think of this in really simple ways. The information in SCR gets into the SCR, the additional information, in one of three basic ways. Either it's part of a summary data set within our GP record, so that would be the information from EMIS Web in terms of active problems or significant past problems. In System 1, that would be the System 1 summary. For IMPS Vision, that would be the Priority 1 item. So either it's part of a summary data set, or it's part of a key data set. So here that would be information relating to end-of-life care or communication preferences. And that's as defined in national data sets, the 1580 and 1605 standards. So it's part of a defined data set. Or it's a manually added item. So then there's an individual tailorability of the SCR to add any further coded information from the GP record into the SCR. So it has that degree of flexibility. It gives us an opportunity. In terms of the Accessible Information Standard, we can support the Commissioner and GP practices to meet that legal duty of the Equality Act to make reasonable adjustments to support disabled people. This legal duty is anticipatory, so where organisations such as GP Out of Hours are seeing our patients on our behalf, then this can help us to support those organisations to provide appropriate care for these patients. The SCR Additional Information Dataset includes all of the clinical codes defined in the 1605 standard, as well as some other stuff that surrounds that, sensory and physical learning disability, information to do with carers, advanced care planning, and other preferences. So it's a set of information which, with the patient's consent, is added to the SCR of the patient. It uses existing information in the GP record. Once the patient consent for additional information is recorded, that's automatically included. So this is starting to move us to a position where I can record the information once in my clinical system and share it more easily. The information about this, in terms of the information in the inclusion dataset, is included in an overview document we've published on our website, and we've just broken down the various codes into logical groupings, so it should be sort of an easy to access and use document, and the links available there. Recognising there are local systems, regional systems, national systems to share information through other means other than Summary Care Record. How does Summary Care Record fit into that patchwork of other stuff? I think the position that we have with this is to say we fit quite comfortably alongside those solutions because we do something different that complements those other solutions. So we provide a nationwide data sharing solution. So we can help where there are boundary issues with patients who can be attended by one provider or another, where there's varying data sharing agreements in place, or patients who have been referred out of area or to tertiary centres. We complement local record sharing, and complex care coordination will still occur at a local level using those local systems. We provide a cost-effective solution for those settings that have a lower digital maturity and where local solutions are not in place. So we can help those organisations, even within a particular area where there's some good record sharing occurring, that have got a lower digital maturity. And we can provide a cost-effective opportunity to accelerate local record sharing where those plans are not as advanced and developed. Let's try and make this real with an example. Lawrence, in this example, is a middle-aged man who's got moderate learning disability. He's difficult of hearing. His speech can be difficult to understand, and he gets anxious with people he doesn't know. His sister is next of kin, and she's very involved in his care. Lawrence attends for an annual health check at his GP practice. So the key here is linking to our existing routine review processes. So that might be an annual health check, or it could be our routine chronic disease review appointments through QOF that we do, or to do with reducing unplanned admissions, or to do with community matrons and their work with patients with frailty in the community. Key information from his healthcare passport, including his phobia of needles and his interest in football, is recorded in his GP record. So information from patients' healthcare passports, we're not going to include all of that information in either the local GP record or in the SCR, but we can flag the existence of that document, we can signpost to that document, and we can probably include some really basic summary information within our record and within the SCR as well. In discussion with Lawrence and his sister, the GP makes a best interest decision to create an enriched SCR. So this is about those patients who lack the capacity to consent to additional information. we've agreed with the BMA and the RCGP a position statement regarding this, that the GP can make a best interest decision on behalf of those patients to include additional information for those patients. Then Lawrence, 6 months later, he's brought to A&E with a carer. He's been refusing to eat for a few days and he's clutching at his chest. So a reasonable sort of attendance at A&E. But there it's an alien environment to him. His SCR is accessed, which shows contact details for his sister, so we're doing something about signposting there. It also shows anti-inflammatory medication that he's received recently and that he's been previously treated for gastritis. So it points to a diagnosis, it points to a causative agent. And this is pretty simple information that can be easily included within the SCR. Lawrence initially refuses blood tests, but he's persuaded to have them by using local anaesthetic cream and a chat about football. And he's found to be anemic. There's something here about diagnostic overshadowing. So the clinician may put down these presenting symptoms to do with his underlying learning disability, about reduced access to diagnostics that occurs in this group as well. But here an endoscopy is arranged which is supported by his sister, and he's found to have a gastric ulcer, so treatment can be started and he's discharged home. We've got a lot of positive endorsement from patients and patient groups and domain leads within NHS England, but I actually really like this quote, which is from a GP who works in out of hours and just gets the point of sharing information. He says, the enhanced functionality to create enriched SCRs is simple. I can record information once and share it easily, which is fantastic. As an out-of-hours GP, I know the importance of making sure essential patient information can be accessed. And thinking about the future, the National Information Board Personalised Health and Care 2020 references the need to open up access more widely and further develop the SCR. So there are plans in terms of the future roadmaps for the development of the SCR. But there's a demand for a wide range of other care professionals to have access to this resource and to be able to benefit. Within that caveat of the patients giving their consent to view that information through permission to view. The SCR Expert Advisory Committee is established, and that ensures that proposals to expand the scope of the SCR are subject to some consultation and analysis. It includes representatives of patients and the public, clinical professional bodies and the Royal Colleges. And it seeks input from wider audiences and advice from relevant stakeholders. So we have a mechanism in place to improve this resource further, but subject that to some rigorous external debate and analysis and trying to make reasonable progress together. In terms of sort of future developments, we can extend the benefits to more care professionals. So delivery now into key areas such as community pharmacy is underway. But scheduled care in hospitals is now something that will start to develop over the next few months. That's cardiology clinics, respiratory clinics, gastro clinics, pain clinics, pre-op clinics who can really benefit from this resource. Discovery work in new environments such as care homes and social care. Improving the usability and user experience, so that's further integrating the SCR with core systems, either as fully integrated viewers or one-click access through the system that you would natively use. It's about mobile access, so we've piloted access to the SCR now through an iPad, where the smart card's been replaced by the device, and we've had excellent feedback from that. And providing further access, so access to further critical information, so signposting or holding information from other sources. That might be key static documents like discharge summaries or care plan information. And we may be able to flag key information, such as communication requirements or learning disability or special patient notes. So making that information very visible to those who are viewing the SCR, and that's work that's underway. I'm very grateful for your time listening to that update really about summary care record. We just really want to connect with practices. We want to make you aware of this resource, and if your practice is interested in starting to get to grips with and using additional information, then please be in touch with our team. I'm available today and our contact details are there. So thank you for your time.